Ik denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé, complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva succedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial. Parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei niin kuin ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who in effect can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato a questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori. Sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
I'm an intensive care nurse, and I'm proud to work with a multidisciplinary team to work together to fight COVID-19. Together, we are intensive care medicine.
I'm an anaesthetist, and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I'm a primary intensivist, and I'm proud of it. We intensivists are working together side by side to fight COVID-19. Together, we are intensive care medicine.
I am an anesthesiologist, and I'm proud to be an intensivist. We intensivists working together to fight the COVID-19. Together, we are intensive care medicine.
I am a surgeon, and I'm proud to be an intensivist as well. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Good afternoon, all of you. It's absolutely great to be with you to try and share some aspects which just are specific to metabolism. I'm myself Mette Berger. I'm the chair of the MEN section, which stands for Metabolism, Endocrinology and Nutrition. And we're going to try and present to you what is specific about the nutritional and metabolic management of the critically ill COVID patients. To do that, we have three great speakers. And we will try to address and show you what these patients have special. These COVID patients tend to develop into persistent critical illness, and this is special in itself. Are they different from the others? We will show. They usually come in with predominant respiratory failure, but you well know that they have several other organ failures potentially together. Does this influence metabolism? Does this influence energy expenditure? Are they special at admission? All this we're going to try and discuss. And of course, we will have questions at the end. Our first speaker will be Arthur van Zenten. Who is Arthur van Zenten? Actually, first he will talk to us about the assessment of these patients. He is a professor of nutrition and metabolic stress at the Wageningen University and Research Hospital. He's the head of his ICU. He has been with the ICU groups of guidelines for ESPEN, and he's associate editor of Clinical Nutrition. Of course, he's been a lecturer for multiple lectures, and it's my pleasure to ask him to start his presentation. Please, Arthur, this is your turn. You have the word.
Thank you very much, Mette, for this kind introduction. And in this presentation, I would like to address bioelectric impedance assessment in critical illness. First of all, here you see my disclosures, but I have no conflict of interest to any company in the field of BIA, so bioelectric impedance assessment. And I have to give a lot of gratitude to my PhD candidate, Hanneke Mone, who published an excellent review in Current Opinion and published the data of the BIAC-90 study on BI assessment in ICU patients with COVID. I'll come back to later during this presentation. Now, first of all, why would it be interesting to know something about the body composition of your ICU patients? First of all, if you get an impression of the body composition, you will know whether there is overhydration, so you know something about the fluid balance. Maybe we can also use it to give an impression on the nutritional dosage, in particular the protein dosing of ICU patients. And we can follow over time maybe the loss of muscle mass that can be marked in COVID-19 patients. And also it's possible to get an idea about pharmacokinetics of drugs. So I will show you some data on this aspects in the presentation. Now, we can measure body composition very simple by height and weight, and then we have the BMI. But then we run into problems because we can have a more muscular type or a more sarcopenic obese patient. And why is this relevant? Now, this is work by Peter Weiss, and you see here 2 CT scans with 2 patients with exactly the same BMI, 30. But in the left panel, you see in the red the muscles in the back at the level of L3 of a CT scan is more pronounced, so there are more muscles, so the lean body mass is higher. And in this study, it was shown that those patients admitted to the ICU with a normal lean body mass compared with patients with a low lean body mass had a better survival. And we know that a high BMI is associated with better survival in the ICU. It's called the obesity paradox. But if we correct all these covariates for these aspects, we see it's actually the muscle area. So the muscle mass is more important than the fat mass of these patients with respect to survival. So it's important to know in what condition your patient is admitted to the ICU. We can measure body composition by several techniques: hydrostatic weighing, isotope dilution, DEXA scanning, CT MRI for routine, or air displacement plethysmography. But all these techniques are costly, laborious, or not feasible in critically ill patients. So BIA is more simple to perform. And first of all, we have to know how it works. Now, impedance is the vector analysis of resistance, the opposition to flow of a current, and the reactance, the opposition to a current change due a material's capacitance. So when an electrical current is sent through the body, tissues present varying resistance levels. So electrolyte-rich body water tissues are highly conductive, like muscles. But fat mass is less conductive, so higher resistance. So reactance is proportionally to the cell numbers and their integrity due to membrane capacitance. Now, single BIA devices most of the time use 50 kilohertz to measure impedance, and they measure extracellular water because low frequency cannot pass the cells. So when you use high frequency BIA, you can go through the cells and you also have an indication of intracellular water. And this is the multi-frequency BIA technique. And when you have this information, you can break down the body composition into components depicted in this slide. So the protein mass, intracellular, extracellular water, bone mineral content, fat mass, and so on. And you can know the fat-free mass or the lean body mass, and you know more about the exact body composition of your patient. When you use segmental analysis, you also get an impression of several parts of the body, so the trunk and the extremities. This is important also to study whether visceral fat distribution is important in certain patients. Now, what is phase angle? When an electrical current passes a cell membrane, reactance causes a time delay, creating a phase shift between voltage and current. And this phase angle describes the difference between the voltage and the current. And a high phase angle is therefore consistent with large quantities of intact cell membranes and body cell mass. The greater the number of cell membranes the signal has to pass through, the greater the reactance and therefore the phase angle. So typically a normal phase angle is above 6, and ICU patients most of the time have lower phase angles. To use this technique, you need an analyzer. This is the analyzer we used, and you have to input into the machine the height, weight, and sex of the patient. But it's important to do this very, very properly. So measure the height and measure the weight and not estimate it, because otherwise you get wrong readings. And typically it only takes 3 to 5 minutes, and then you have the readings of the device. There's also BIFA plots, that's bioelectric impedance vector analysis. That's a depiction of the phase angle related to a reference population. And when you plot the data of your patient in this kind of graph, you get an impression whether the patient is anabolic or in cachexia situation, or dehydrated, or has acquired more water, so edema. And so this gives you an idea where the patient is also during ICU stay. Now, with respect to outcome prediction, we know that the phase angle, when it's low, it's associated with long-term and short-term mortality outcomes. And when the phase angle increased during ICU stay in the first 5 days, you see more survivors. When it declines or drops, you see more non-survivors. And there is a negative correlation of phase angle with ICU ward and hospital lengths of stay, duration of mechanical ventilation, Apache 2 scores, and the severity of COVID-19 disease. But of course, there are various problems here. What are cutoff values in ICU patients? We study heterogeneous populations. Is the same true for septic patient? And isn't a low phase angle a reflection of poor underlying health before ICU admission? We can also use it for hydration parameters. So we can measure overhydration. And there are studies showing that 5 days after ICU admission, overhydration, so increase of extracellular water, is associated with increased numbers of non-survivors at 60 days. BIFA plots can predict mortality better than cumulative fluid balances in the ICU. And when you have this higher ratio of extracellular to total body water, it's associated or found in non-survivors and patients with longer duration of ventilation, independent of Apache 2 score. When you compare BIA with CT scan muscle mass measurements, it's highly correlated, but there's a low agreement in patients with a high muscle mass. So there we still have problems. And we also have problems with overhydration, because in that situation, we will overestimate the lean body mass, because it's considered to be lean mass with a high, with a low resistance. Now, with respect to nutrition management, we can calculate the body cell mass and the fat-free mass. So we know something about the lean body mass. And of course, during malnutrition and ICU stay, the body cell mass will go down, will lower. And we know that these raw parameters, so reactance, resistance, phase angle, and impedance, are associated with outcomes. So we know a low phase angle identifies patient with a high Nutrix score. It's associated with protein energy wasting and renal replacement therapy. It can detect malnutrition. And it's also associated with muscle weakness. So in a way, it's associated with ICU acquired weakness. We also know is associated with the loss of the lean muscle mass in those patients. But maybe we can also use it for protein dosing, because when we know exactly what is the lean mass, we can maybe better define the protein doses we have to give to the patient. Now, this is a paper by Jones, and they use this plot to follow up patients over time in the ICU to manage fluids. And this is just a depiction of a patient. So at 1, you see a healthy individual becomes sick, fluid resuscitation goes to number 2, edema, and then a lot of loss of lean body mass during ICU stay occurs. You go to number 3, and then you start de-resuscitation with diuretics. You go to number 4, and then finally the patient goes to the anabolic phase, number 5. So you can follow your patient during ICU stay. There is another group from the Netherlands who did some work on GFR measurement, and to predict with the multi-frequency body cell mass of BIA what is the GFR of patients, and then you can use it also for pharmacokinetics dosing of medication with the distribution volume in, for instance, the lean body mass. We did a study in COVID-19 patient, obese patient, and we wanted to know whether body composition played a role in those patients who could stay in the general wards or who had to be admitted to the ICU. And furthermore, whether visceral fat deposition, what is found more in males, is relevant for the outcome. First, we had to correct the data because they had increased extracellular water to total body water above 0.38. So we had to readjust all the variables of BIA to a so-called dry weight or normal hydration situation. Here you see the results of the patients. We studied 45 patients, and you see the difference in the groups is only in the SOFA score and the CK levels Otherwise, the patients were rather similar in the ward in the ICU. But of course, with respect to outcomes, those patients in the ICU were more sick, so less hospital-free days and more complications like thromboembolic events and other complications. And also the discharge destination was less frequent back to home and more frequent to rehab facilities, as you can expect. And then when we look into the data who were adjusted for sex and age and all kind of covariates, we made a composite score of ICU admission, mortality and complications, and only the phase angle was the single only variable from BIA measurement that predicted this combination of negative outcome. So all the other factors, especially also not visceral fat distribution, was associated with the severity of illness in COVID-19. So to our surprise, maybe it's a risk factor to be obese to get COVID-19 and to go to the hospital, but within the hospital, we don't see much difference between patients in the ward and in the ICU. This was replicated by another group recently published in 127 patients that a low phase angle independent of age, sex, BMI, and comorbidities is a significant predictor of mortality risk in COVID-19. In this BIFA plot, you see the patients with the red dots are the non-survivors. So in the cachexia group in the right lower part of this BIFA plot. There are several caveats. Reference values in ICU patients are not available, so we have to do much more research. We don't know what are really cutoffs for normal or abnormal. There is a problem with input parameters. I already told you, you have to weigh the patient. We have death weighing, so on admission we weigh the patients, and you have to measure the height. And it's complex to do corrections or the adjustment for overhydration with BIA, but it can be done. And we don't know what is the influence of changing electrolytes, fever, and fluid accumulation like ascites and pleural effusion. So still a lot of work to do. But to conclude with my personal recommendations, I believe BIA can be of help in the future. It's easy to apply, quick measurements, only minutes, low costs, no transportation of the patients. You can do it at the bedside. There is a low risk of overrated variability, such as ultrasound, few exclusion criteria. It's only not allowed at this moment for patients with pacemakers or ICDs, or maybe during pregnancy, but it seems even in that conditions to be safe. There are many uncertainties regarding interpretation of the BIA data, and that's the reason that we performed a new study, and I hope to show you the data soon, with COVID-19 patients, 150 patients on ICU and hospital admission to have less of this problem of overhydration. So I think it's a potential tool to measure body composition, also in ICU patients. You can measure fluid overload in your patients. You can maybe use it for medication dosing, so pharmacokinetics, nutrition dosing, and I've recently said maybe we have indirect calorimetry for the calories, and maybe for the proteins, BIA can be the muscle indirect calorimeter. We don't know, but could be helpful, but we have to do more research together, and I'm happy to see that more and more papers are emerging now on this excellent and interesting technique. So with that, I'd like to conclude and give back the word and the floor to Mette Berger. Thank you for your attention.
Dear Arthur, thank you so much for this really important presentation on BIA. It has been proven in large numbers of ICU patients in the paper, the French ICUs, to really be correlated to mortality. You insisted on the fact that we don't have the cutoffs yet, but sort of between 3.3 and 3.5 of phase angles seems to be a cutoff for high risk of mortality.
Yeah.
Easy to do, really. It's very rapid. Within 5 minutes, it's done. So we have finally numbers. So thank you for showing this. We will discuss it better at the end. I mean, metabolism has to become something more than beliefs. These are facts. And we're getting there. So getting there, we have other measurements. And just now, we're going to get the next topic, which is energy expenditure. You mentioned indirect calorimetry. We have Elisabeth de Wel, who was able to measure energy expenditure in these COVID patients. She's a surgeon and intensivist. She's an associate professor in Brussels of intensive care medicine. She's also the medical director of a department. She's leading home PN facts. She's an executive board member of ESPN. Actually, she is our IT specialist there. And she's publishing and she's doing research. And she also, on the top of that, mother of 3. So please, Elizabeth, show us what you know about the COVID patients regarding energy expenditure. You have the floor, please.
Thank you, Mette, for this kind introduction. Now I know why I'm so tired at the end of the day. So indeed, let's look at energy expenditure. I have some disclosures, of course, to show. As we all know, we have been confronted with a lot of challenges in this pandemic, and everybody in ICU with their specialty really went into their domains to make sure that we had the highest level of care for this new disease and those new types of patients. And the same thing was about nutrition. We were all challenged to give our best, and I will share with you some of the results. Of course, very quickly, there was some guidance provided by, for example, the European Society of Clinical Nutrition and Metabolism to guide us what to do in nutrition in this population. And of course, we could only look back to our evidence and our experience we had with other ICU patients to try to put them on this new population. And what is still standing up is that indeed, especially also intubated ICU patients really need a medical nutritional therapy. This is part of their therapy. It should be high level because it can change their outcome. And this is why we really want to address this, that you need the feeding tube, you need the access, you need to use the parenteral if necessary, because what you really want to do is get to the target of your nutrition. And talking about the target, this is where we really want to go. When we look at the European guidelines on nutrition in intensive care by many authors here present, like Arthur and Mette, we can say that there is a large consensus on the available literature and evidence that if you want to know the metabolism of a critically ill patient, you should use indirect calorimetry. So this is a strong consensus. If you want to know that number, measure it. This is a firm guideline from the European Society. Now also our American colleagues in their guidelines indeed also state that if you want to know the metabolism of your patient, and most of the time you will want to know this for nutrition, but it's also very important to have an image on your patient. What is the metabolic rate of your patient? Are they hyper or hypometabolic? So also our American colleagues, by their recommendations, they state that you should measure by indirect calorimetry the metabolism of your patients. Now, why has this become so important and why is attention increasing to this part of therapy? Because we have seen a few years ago from the group of Pierre Singer that it is indeed of vital importance to dose correctly the calories and the proteins. You cannot provide 1.5 liters of enteral nutrition to every ICU patient or give 1 bag of PN to all your patients. It needs to be correct in the same way that antibiotics should be correct and your vasopressors should be correct. The only difference is that the effects are sometimes less visible. So as you can see here by this very known publication, there is this safe zone where you want to be with your caloric dosing and the proteins, and please let's hope indeed that we can be guided by a measurement soon, and it might be BIA. But if you use indirect calorimetry to guide nutritional therapy, as is done in this population, you will have a mortality benefit. And I was very happy, and I think a lot of us, to see this publication in Critical Care, where somebody who's not really from the nutrition world performed the meta-analysis on energy delivery guided by indirect calorimetry, and indeed states that by meta-analysis, indirect calorimetry guided energy delivery reduces the mortality of critically ill patients without side effects. So if you want to change the mortality outcome of your patient, you should implement this technology and go for this goal-oriented strategy. I mean, this publication is the final word. You really need to measure it. When do you need to measure it? We are discussing about it, and I really like this pragmatic approach by Takuo Shima, where we said, okay, by day 3 in ICU, you really want to know the metabolism, because this is the time point where your prescription needs to be adapted to your patient. You have this ramp-up phase, but then it really needs to be at target, as we have seen before in the Sussman paper. So it's very important on day 3 or 4 to do the measurement. Personally, I think that we should have a continuous measurement later on because patients change. But for the moment, and there is some literature to defend this, you can repeat the measurement at certain time points and adjust your therapy to what you have measured. When? Well, especially when the situation of the patient changes. This is very important to redo your management and to adapt your strategy. Now, during the first COVID wave, indeed, all of us dove into our data and we had to make clear recommendations. So we made checklists for everything here in Brussels, for intubation, for vasopressors. You know, we put all our protocols and made them in one easy list, because you also have healthcare practitioners who are not so familiar with ICU world that come and help, and they want clear guidance. Now, this was our chart that we made. And you can see that it is based on the ESPEN guidelines, of course, and that we also really went very practical. Put the feeding tube when the patient is there in ICU. Start with your enteral nutrition, whatever which formula, because we're having stock problems and so on. Start with the enteral and then refine. Go to target. Put it right. And this is where the indirect calorimetry comes in. And you can see that in March 2020, we said, okay, and otherwise you use 25 times the body weight per patient, because this is the ESPEN recommendation. And for the proteins, 1.3. So this was a checklist. We put it on the wall. We made it available. It was very popular. And I think that it helped us really, especially in the first wave. Now, let's have a look at the data, because indeed, it was very important to learn to know the COVID-19 patients and to better understand them, to be better able to help them. So what we did, first of all, was adapt our way of performing indirect calorimetry, because in our institutions and in a lot of institutions all over the world, this is daily practice. This is daily practice, but of course, when you're confronted with this new situation that you don't totally know and understand, we became very, very careful. So first of all, the physicians did the indirect calorimetry. We have trained and certified dietitians who can normally do the measurements. So we took them a step back because of the manipulation of the ventilator. We designed a way with clamping the tube, putting the respirator in an apnea, putting a plastic shield over the patient so that the deconnection and the connection was as safe as possible, so to create this safe environment. But on the other hand, we really wanted this to work, because if you talk about indirect calorimetry for 10 or 15 years, you need to act on what you preach. So this is what we did. And together with Claude Pichard and Pierre Singer, we also published this way on how to perform indirect calorimetry in COVID-19 patients. Now, on the picture here on the screen, you can see that once again, we saw those examples of patients with very high and very low metabolisms. Here you see a 21-year-old patient overweight with a high BMI, where we had a resting energy expenditure of almost 2,400 kcal, but which was still less than predicted. This is the number you need when you want to prescribe nutrition. So this is what we were doing over and over again to be able to tailor our prescription. Now, let me share with you some of the data that we have up to now. We were already engaging patients of ICU in a study where we look at nutritional adequacy in ICU and in the ward. So we follow the patient through their hospital stay. We also included COVID-19 patients, and we did the same thing. So we look every day at the intake of calories, and we compare them to the need. And we do the same thing for protein. Now, when we had a first look back on those patients, we could firstly see that, I don't know why, but COVID-19 patients had a lower intake than the non-COVID patients, probably because of restrictions. It might be of the shortage that we had, or the teams that were not, acting as they should, or overwhelmed. But we had a lower caloric intake in the COVID patients than in the non-COVID patients on the calories. Now, when we go to the next slide, here you can see once again this adequacy. And this is our data that we use to improve our strategies. And here you can see once again, in the COVID-19 patients, in ICU, they had an acceptable adequacy of nutrition. This means above 70% of what they needed was actually given to the patients. When we follow the same patients to the ward, we see that the intake drops. When we look at non-COVID patients, we see that the adequacy was higher in ICU, and indeed there is a problem in the ward. Those are the same patients that we followed up. So this is about nutrition adequacy, where I can tell you, please take care that also those patients are well fed and that you follow them up after ICU discharge, because this is really the dark side of the moon, is when they are released to the floor. Another part of those interesting results are the resting energy expenditure measured by indirect calorimetry. And here you can see that the numbers are slightly higher in the COVID-19 patients, so the mean was above 2,000 kcal per day. But of course, because of the higher body weight of those patients, when you express this in kcal per kg per day, you could still see that there was a higher metabolism. So this is interesting data, and we are still gathering data. This is not published yet, so it's not reviewed, but I want to share it with you. So we are seeing differences between the COVID and the non-COVID patients, and this will enable all of us to better fine-tune our nutritional therapy to those patients. And I'm going to share with you some of the data here. Like, as you can see, is it worthwhile? Do we need to take the risk to perform indirect calorimetry in those patients? We cannot just stick with the Aspen guidelines. I defend them all over the world. Well, let's have a look. You can see here that in this Bland-Altman plot, when you compare resting energy expenditure by indirect calorimetry to the 2025, so let's take 22.5, you can see that the variations are rather large. The differences are clinically irrelevant. Those are all the measurements that we have done in patients that we followed up in time. And you can see this goes above 500 kcal, 1000 kcal. So if you would make this mistake day after day in your treatment, you would really make a large iatrogenic over or underfeeding. So this was our first finding when we look at the data. Another more clinically relevant or comprehensive one is that if you look and you take this safe zone of 2025, 70% of the prescriptions that you would make are not correct when you use the body weight equations. We know this from before, that especially in the obese, there is a large difference between measured and calculated. Even if you take adjusted body weight, the difference is large. And here you can see once again, but this is reinforcing our ideas. You cannot accept 70% of incorrect prescriptions. When we look at the timeline of metabolism, because if you want to know how your patients evolve, you can see here in ventilated ICU patients that indeed this metabolism is changing. So we have an increase of metabolism from the length of ICU, and you will see in the ventilation, it's kind of the same. So you can see it increase to day 10 or 12, then it goes down, and then the less number of patients that are still in ICU after 40 days, there would be an increase of the metabolism. Of course, what we're doing now is correlating this with all kinds of clinical parameters, because they can have a bacterial infection, they can have a lot of problems that could explain this, what we see. But as you can see here, this also means that you need to adjust your therapy. You cannot start with a body weight of the beginning and have a flatline prescription when this is the real metabolism going on. And when I looked around, and I was very happy to see that our American colleagues in person of Paul Wischmeyer and Jeroen Mollinger and his team also went in to the same subject. And when we look at the data that they also published and shared, we can see that also they see this increase in metabolism around day 15. We compare them to our ventilator days. We see a little earlier onset of this rise. But I think that the most important message that we want to share with you by having indirect calorimetry in ventilated COVID-19 patients and beyond, so also non-ventilated on the ward, is that they have a higher metabolic rate, but there is an extreme variation. We saw patients with very low metabolism and very high. And if you are responsible of prescribing enteral, supplemental parenteral, or total parenteral nutrition, you should be aware of this number so that you can easily adapt to the person, to the patient in say, and that you can change by the data that we have seen from critical care publication and from Zussman, that you can actually change the mortality outcome of your patient. So if we see the Brussels data and the US data, I think the most interesting part here, because most of its BMI is comparable, we went on for a longer time and so on, but they found this 25 kcal per kg per day number, but it's once again an average. We had 24, 23, but the variations were very large. So please don't be misled by the median value and keep into account and keep in your memory this very large deviation and the fact that 70% of your prescriptions will be incorrect when you base them on the body weight of the patient or other equations or formulations that you would like to use. So I would like to thank you for your attention, and I look forward to the questions. But as we have seen with the BIA, as we see here with indirect calorimetry, those are technologies that should really enter ICU to bring nutritional therapy to the level it deserves, because it can change the outcome of the patients. Our machines should be next to all the other machines in ICU. Our brains should be there to guide us in nutritional therapy. And if you don't have access to the technology, I would say it's a challenge, but especially today, always take a challenge. So thank you for your attention.
Well, dear Elizabeth, thank you so much for this great talk. I mean, again, it shows that there's only one way to go. We have to measure, and then we will improve the outcome of our patients. Body weight, we never know. When we calculate adjusted body weights and so on, we never know. So we just need indirect calorimetry. And clearly, this will improve outcome as BIA to select the patients regarding proteins. So we will continue now, because now we know body composition, we know about the energy expenditure, and some patients do develop, need only non-invasive ventilations, while others go to the extreme of ECMO due to their problems. So we have our third speaker, Gunnar Elke, who is going to deal with that. Who is Gunnar Elke? He is first the deputy of our men's section. He is a consultant in the Department of Anesthesiology of Kiel. So he has wind on the North Sea just now, from the Baltic rather. He's the coordinator of the German guidelines for nutrition in critically ill patients. And he has been doing quite some research in this area. So please, Gunnar, tell us about how to handle these patients who are very special. Thank you.
Thank you very much, Mette, for this kind introduction, and a warm welcome from Kiel, especially today with 30 degrees Celsius outside temperature. I hope you can see my slides. And first of all, here are my conflicts of interest. And to give you an outline, I will start with nutrition-specific clinical considerations during ECMO therapy and NIF, before I will then briefly summarize the latest evidence and current guideline recommendations in the short 15 minutes ahead. So the first question is whether our patients lose nutrients via the ECMO circuit. This recent experimental study from last year evaluated the amount of nutritional supplements absorbed in an ex vivo ECMO circuit maintained under physiological conditions for a limited time span of only up to 24 hours. And a dose of nutritional supplements were provided and calculated for a 70 kilo patient in the ICU. The main results were, quite surprisingly for me, but that there were actually no significant differences between the ECMO circuits and a control for any of the measured micro or macronutrients, but keeping in mind the ex vivo design of this study and the very limited observation time. Danny Baer and co-workers examined the relationship between skeletal muscle index and density in a prospective observational study in 215 patients requiring veno-venous ECMO for over 72 hours. You can see the age of the patients, quite young. And around 20% of the patients had low skeletal muscle index and low skeletal muscle density on commencement of VV ECMO. And the low skeletal muscle index was associated with a longer ECMO duration, while higher skeletal muscle density was independently associated with ICU survival. So quite intriguing data from Danny Baer. In relation to this, two smaller cohort studies, particularly in critically ill COVID-19 patients, revealed that on the one side, ICU-acquired weakness as diagnosed by the Medical Research Council SUM score, already presented with ICU-acquired weakness at ICU awakening in 3/4 of the patient, and still in 1/3 of the patient upon hospital discharge, ICU-acquired weakness was still present. And another study could show, and probably in relation to the development of ICU-acquired weakness, that survivors of critically ill COVID-19 disease develop post-intensive care syndrome with a physical component being mostly impaired in these patients. Keep in mind, very small subset, but intriguing data in my opinion. COVID-19 patients, what are the barriers to specifically enteral nutrition in patients requiring non-invasive ventilation? COVID-19 patients often do require high pressure respiratory support before probably the next step comes with intubation. They have a higher incidence of GI intolerance due to pre-existing malnutrition, as Arthur van Zanten already quite nicely showed in this presentation, and they do have a prolonged ICU stay. NIF per se technically impairs oral and enteral feeding, and of course, patients do have a certain risk of aspiration, especially in the presence of gastrointestinal complications when they are fed enterally. So with a nice view on the Baltic Sea, we will have a glance at the evidence of medical nutrition therapy during ECMO and NIF in the next few minutes. So concerning the comparison of the nutritional route per se, these two major large randomized controlled trials, on the one hand, the calories trial, on the right hand, the Nutria tooth trial, you're probably familiar with, both showed that comparing the route enteral versus parenteral nutrition, not the calories and protein provided, only the route, did not significantly influence the measured endpoints like mortality or different morbidity parameters in a general ICU population, and on the right-hand side, invasively mechanically ventilated patients in shock. Actually, the incidence on ECMO therapy in both studies was not available, and also, especially in the right-hand group, you must keep in mind that patients were invasively mechanically ventilation and not received a non-invasive ventilation. Quite interesting was, although not specifically influencing the major clinical endpoints, but patients in both studies receiving enteral nutrition as compared to parenteral nutrition had more gastrointestinal complications that, especially in the Nutria 2 study in patients with shock, were quite severe. Concerning specific evidence on medical nutrition therapy and ECMO, Christian Stoppe, my colleague from the Würzburg University Hospital, and I reviewed 6 observational studies in this review here between 2004 and 2018. A total of nearly 500 patients were studied, and the main results where that enteral nutrition is generally feasible in patients on ECMO, and that the ECMO mode per se was no barrier for any form of medical nutrition therapy, and in particular EN. Another review revealed that across 6 studies evaluating the incidence of non-occlusive mesenteric ischemia or bowel ischemia among patients undergoing ECMO and receiving enteral nutrition only occurred in 3 of the reported studies with a fairly low incidence rate of 0.7%, and not EN, but actually the severity of anal illness explained the differences in the bowel ischemia rate across these studies. Another observational study from this year, which is still currently in press, was an observational study included 90 patients with refractory out-of-hospital cardiac arrest treated with eCPR and targeted temperature management, where they compared or divided the patients into an early enteral feeding group commenced within 48 hours and another group where enteral feeding was started in a delayed mode, so over 48 hours. And actually the patient's very small cohort again was actually delayed enteral nutrition associated with improved neurological outcome in these patients, but all other clinical endpoints studied were not different, and adverse events related to enteral nutrition were not associated with the timing and initiation. But in my opinion, these results rather indicate that the amount of macronutrients provided by the early enteral feeding approach is probably more relevant in terms of outcome than the feeding route per se. Another observational study, I'm now going to the non-invasive ventilation data and medical nutrition therapy, included 1,075 patients receiving NIF for exacerbation of COPD for over 2 days or any form of acute respiratory failure. And you can see on the left-hand side that actually enteral nutrition compared to no nutrition was associated with a higher 28-day mortality and invasive mechanical ventilation needs, but still keeping in mind that the observational design just shows hypothesis-generating results. Quite similar, another observational study on NIF and enteral nutrition in only 107 patients receiving NIF for over 2 days also showed that enteral nutrition was associated with a higher incidence of airway complications defined as the total number of episodes of vomiting followed by desaturation, mucus plug, and aspiration pneumonia. So we have now seen that actually no randomized controlled trials exist on specific aspects or effects of medical nutrition therapy in patients receiving NIF and ECMO. So it's mainly based on observational studies, but now we come to the current existing guideline recommendations and how experts from all over the world interpret these evidence. So actually, as an update from last year concerning the COVID-19 pandemic, the ELSO organization specifically was updated on the treatment of ECMO therapy in COVID-19 critical ill patients. And I was quite happy to at least find also a statement or recommendation concerning medical nutrition therapy in these patients. And the ELSO recommends that early enteral nutrition within 48 hours, commencing at low doses and advancing to target over 3 to 5 days, should be conducted in our patients. And you can also see they recommend the enteral route, but they also recommend to build up your patient and keep an eye especially on the macronutrients provided, especially in order to avoid overnutrition in the early acute phase in our patients. Then we have actually recommendations on medical nutrition therapy in COVID-19 patients from the ESPEN and the ASPEN Society. Again, no evidence from RCT so far on medical nutrition therapy in COVID-19 patients, but expert statements. And what do they tell us? EN should be started via nasogastric tube within 24 hours of intubation. Post-caloric feeding should be performed, especially in patients with gastric intolerance after prokinetic treatment or in patients at high risk for aspiration. And no enteral nutrition concerning the data from non-COVID populations, especially Nutrient 2 study, in the presence of uncontrolled shock and unmet hemodynamic and tissue perfusion goals, and especially when you're still in the process of escalation of vasopressors or inotropes, or you do have signs of bowel ischemia in your patients. Non-inventive ventilation per se does not represent a limitation or contraindication for enteral nutrition according to the ESPEN statement, but be reasonable. That means in terms of neurological and gastrointestinal function, especially when you see your NIF therapy as a last line before intubation, be careful with enteral nutrition to avoid aspiration when the patient needs to be intubated. And keep in mind, all patients during NIF should be, in case there is no contraindication to head of bed elevation, should be placed in this position. What do these statement papers tell us about the role of parenteral nutrition? Parenteral nutrition reduces the risk of exposure if nasogastrocranial access is difficult and central line is present anyway in the COVID-19 critically ill patients. And the decision for parenteral nutrition should be made early in the acute phase already, especially because the patients do have pre-existing malnutrition and supplemental calories may be delivered via the parenteral route early in the acute phase to reach the recommended caloric and protein goal, and especially probably to avoid gastrointestinal complications. Then finally, we do have current nutrition guidelines from the European Society of Intensive Care Medicine and from the ESPEN and from the German guideline published last year, so quite new. And what does the ESICM guideline recommends? They state that actually what I've said already, no RCTs, no prospective cohort studies could be identified, only 4 case series in adult patients with ECMO, but still they do recommend using early enteral nutrition in patients receiving ECMO. The ESPEN guideline endorses the ESICM guideline and also recommends that early EN should be performed in patients receiving ECMO once they are hemodynamically stable, and they have not provided any specific recommendation on the route of nutrition for patients on non-invasive ventilation. The German guideline states that in the absence of signs for severe intestinal dysfunction and or hemodynamic instability, enteral nutrition may be used in all phases of the disease, so careful recommendation, and in patients requiring non-invasive ventilation may receive medical nutrition therapy via EN if they have effective reflexes protecting the airways, so that the indication for your NIF therapy is correct and if the gastrointestinal tract is functioning. And finally, I would like to conclude and reference Pierre Singer, who in his editorial asked the question, to eat or to breathe. His answer was both, because he is, as we are, quite aware on the dilemma that patients have to do both, and instead we need to use effectively the combination of probably new respiratory support devices during non-invasive ventilation with the appropriate route for nutrition therapy. And then I came over in this respect on this innovative report from Limais and co-worker, where they invented a so-called Charlotte valve, the orange plastic device you can see here that enables the connection of the simple branch circuit of the ventilator on the right side and the airproof passage of a nasogastric feeding tube on the other side. During the first wave of the pandemic in Italy, where NIF mask became unavailable anymore, like many other things already. And it was quite innovative that they used a snorkeling mask from a large French sport brand to overcome this problem. So I would like to conclude that evidence on medical nutrition therapy during NIF and ECMO and outcome is primarily based on observational data. ECMO as a potential contributor to worsen nutritional status, probably more due to the critical illness per se, rather than the nutrient loss via the ECMO circuit. NIF as a potential barrier to sufficient EN, and the risk of airway complication remains unclear because so far we don't have causal data. Guidelines expert statements from major nutrition societies recommend the enter route as first choice for ECMO once the patient is hemodynamically stable, for NIF in case NIF indication is correct and GI tract is functioning. Beware of the AOB position, and parenteral nutrition has its, in parentheses, pragmatic place, especially because our patients enter the ICU malnourished, and therefore it should already be performed in the acute phase. So thank you very much for your kind attention, and I'm happy to take any questions. Bye-bye, greetings from Kiel.
Thank you, Gunnar. Thank you so much. This was also very refreshing. We don't have prospective trials, but we have data. So I will take questions that have come in, and I will take yours first, and then there's one to Elizabeth. Actually, knowing now that calories and Nutrirea have shown equipoise from PN in teams which are not trained, knowing that enteral nutrition is difficult, would you have an easier go on PN?
Yes, we do have, although, and not only me, but probably most of the audience here are also aware on the results from the EPANIC trial. But again, especially because the number of patients being malnourished in the EPANIC trial too were quite low. We, and apart from COVID-19 patients, but especially malnourished patients, we do recommend in our German guideline that parenteral nutrition could be already started within the acute phase. So let's say in the first week of intensive care unit state, but still keep in mind that it's essential to monitor the individual metabolic tolerance when taking parenteral nutrition, and parenteral nutrition must be as enteral nutrition be cautiously built up in the acute phase. And in my opinion, then parenteral nutrition avoids undernutrition in our malnourished patient and keeps them protected from an overnutrition in the acute phase.
Well, parenteral nutrition will avoid that, but should be ramped up as we do with enteral nutrition. So our guidelines, Espen, say consider it from day 3 on, and especially if the patient comes in with a high NRS score. And that is something we should consider and individualize. So now I'm coming to a question. Several questions have come in on the same thematic to Elizabeth. Are there alternatives to indirect calorimetry? And what do you think about the continuous measurement of energy expenditure?
Well, of course, the alternatives are there. I think the VCO2 method that has been prescribed a lot is the second best. The only problem is that when you have a ventilator that will measure CO2, or you can do it in some other way and multiply it and then calculate your energy expenditure from the VCO2, this is second best. But oxygen is 4 times as important as CO2. So you're working on the weakest parameter. In the equations, I would really not defend one single one. I knew that minute volume is important so that you could use static ones, but also the non-static, but also those with the variables, they lack precision and they are no good. So I think indirect calorimetry, VCO2, and otherwise try to tailor to your patient. And I also want to comment indeed, the supplemental parenteral nutrition is the only way, as long as you don't live in Holland, because they're very good with the enteral route. For us, it was the only way to get to target. We use little bags, like we call them, 1 liter of SPN, a lot of time to raise our adequacy. So this is the first thing. And about the calories, indirect calorimetry, VCO2, please don't use the equations.
And in non-invasive ventilation, we cannot use calorimetry there because we have too many leaks.
Not yet, Mette, not yet.
No, we hope for this answer, but not yet. And that's true.
We are working on that.
And that's true. And now I have a question for Arthur. It's about the protein requirements. Have you dissociated energy intakes from protein intakes based on body composition, or are we not yet there?
Not yet, but we performed a study in COVID-19 patients using Gallagher equations. So there are some equations available to estimate the lean body mass and to set the protein dose based on the lean body mass. But this is what we plan to do, and to adjust the protein dosing to the body cell mass, so the lean body mass, and to see whether this maybe can prevent ICU-acquired weakness or muscle mass loss. But this is something we have to do in the future. It seems that the BIA is rather very well associated to these equations for lean body mass. And those equations have been, well, validated to DEXA scanning or CT scanning and other techniques. So I'm very confident that it doesn't take very long to have this information available and to target proteins on BIA measurements.
Great. There's one question for all of you about prone position and feeding strategy. In our ICU Lausanne, out of long stayers, 42 out of 52 long stayers were prone. They were on enteral feeding with very few parenteral. What is your experience?
Maybe we had like more than 150 COVID-19 patients. I think also more than half were in the prone position, and we didn't use PN in any single patient at all. But maybe that's the Netherlands. We start very early. So when you start early, and in some patients maybe you need some prokinetics, but it's very feasible to use enteral nutrition in COVID-19 patients. And you can just use the gastric route, but because in the guideline we made with the European Society of Intensive Care Medicine under guidance of Annika Reint and Blaser, we also showed that the GRV volume in prone and supine position is exactly the same, and gastric emptying is also the same. So if the stomach works in supine position, it will also work in prone position.
Jean Régnier did a very nice prospective trial on that. Same experience, Elisabeth? Gunnar? Yes, no?
Yes, so we did a lot of enteral nutrition in proning, a lot of enteral nutrition in ECMO. It worked. We used, like I said, supplemental parenteral, especially in the first week while we were ramping up. We had no problems at all. And we don't do gastric residual volume. COVID killed GRV in our ICU. We were working on for years. Stop doing that, stop doing that. And then because you don't want to manipulate,
yes, exactly.
All of us stop doing that because it doesn't make any sense.
Gunnar, could you also feed enteral?
Just agree, and concerning prone positioning, probably or actually the same recommendations as Arthur pointed on in all the guidelines: enteral first, parenteral second, and when you don't reach the calories, what is actually not the problem in COVID-19 patient, then of course there is no indication for PN if the targets are met.
Finally, a comment from someone, and I would like to have your brief reaction. People are disappointed that the industry is not running more into non-invasive ventilation measurement and other indirect calorimeters. You, Elisabeth, seem to have an input there.
Yes, so we may not forget that it was a scientific-driven initiative with an ECALIC work group by Pierre Singer, Claude Pichard, and you, Mette, and all of us. So I think that when we see those new hurdles, we should tackle them. But it is indeed not easy, but it's never easy. And I think that we should really have indeed investment, attention to be able to take those hurdles, because you cannot develop something for ventilated patients when we know that less and less patients are being ventilated, also in pediatric ICUs. So we need to evolve with our technology, with the evolution of ICU.
Yeah, to add a little bit on this, I know that several companies are working on several solutions for non-invasive, for canopy measurement with oxygen, because that's another problem. So I think in the next few years, we will see more interest. And that's mainly due to the fact that our nutrition societies have stated that it's important to do indirect calorimetry. And that will feed the development of innovations in this field.
I agree. So with that, I think we have come to the end of our webinar. I would like to thank you so much, the three of you. You have really presented very interesting data. I would also like to thank the floor, where I got in the questions, because this has been important. And if we have further questions, you might send them in to ESICM and we would answer. So thank you to all of those who have been listening. Thank you to you three speakers and to ESICM for making this possible. Thank you.
Thank you, Mette, for chairing.
Thank you.
Thank
Bye.
you again.
Bye. Have a good day.